Greetings from Apollo, Chennai. Good morning, C3 at Orlando. I am Dr. Reddy, and with me is Dr. Shyam.
Good morning.
We have a big team, Dr. Azhar, Lata, and a lot of technical staff as well. Jayanti, Mail. So, yeah. So, how is the thing? Can we proceed with the case or?
Yeah, let's get started with the case.
Yes.
I appreciate you guys with us today. Thank you for coming to C3.
Yeah.
And let's see what you have. Let's start with the background.
Yeah. So this is a 47-year-old male, a diabetic, had an anterior wall non-STEMI in 5 years back. He had a critical LAD proximally with a small collateralized diagonal, which was a totally occluded vessel. So he was stented with a Zines Prime 3 into 18 mm with an excellent result 5 years back. He was doing extremely well. His tests were negative, but there was a classical history of DAPT, poor compliance, and he had lost to follow-up. The current situation is about 6 days back when he tried walking uphill, almost 1,700 steps, and he developed some angina. He was shifted on a stretcher for a medical care. TROP was positive, and after stabilization, tirofiban infusion, ticagrelor and aspirin, he was shifted over here for further management. The ECG shows ST depression in inferior leads and also
somebody speak only, then we know that.
And T inversion in precordial leads. And echo showed some wall motion in both anterior and inferior leads with an EF of 40. We'll show you the angio run, transradial. We did it 2 days back. Can you see the angio runs there? The LAD stent is seen. A big ramus.
That is fine.
Yeah, the small collateralized diagonal as before. The next angiographic shot can show that the problem is there in the stent. So you can see that the disease is there well before the stent and after the stent as well. There is some a segment of myocardial bridging in the mid segment. But what is important,
I will not mind.
can you see the radiolucencies, filling defects inside the stent and probably just after the stent?
Further reduce it.
Yes, we see it clearly.
You can probably appreciate that. I hope so. Next. The same thing, the TIMI3 flow, but diffusely narrowed segment, both pre and post stent as well as in the stent. Next. You can appreciate a large ramus. Next. And he also has a disease progression with a critical mid-RCA disease. Quite a large RCA. So we went in and did the PTCA and stenting of the right coronary artery ad hoc. Next slide. A 3.530 stent, post-dilated, final shots, right was good. Next, we can show you the final thing, and then the next slide. The current, today we have taken him up for the treatment of the LAD. So this is the plan now. What do you think? What is your thoughts now?
Bad compliance to the dual antiplatelet therapy. You see this mass in the stent. I think that I would, if I had the patient, I would consider doing a gentle thrombus aspiration, because I think there can be a risk of having a distal embolization of this material if you wire and you put imaging catheter down. So I think I'll do a gentle thrombus aspiration and then maybe imaging to see if there's incomplete lesion coverage, if the stent is well expanded, if it needs an extra stent proximally, and if it needs the further post-dilatation to get the adequate size for the patient.
Yeah, I agree. I think in cases like this, OCT imaging is crucial. I think will provide a lot of information if that's available.
So we want to proceed with the OCT. But one issue here is a 5-year-old DES. So the problems of uncovered stent threads where a pure thrombus has caused the entire problem is quite unlikely. This is an issue we are seeing more and more with the late stent failure with drug-eluting stent, and the primary mechanism of failure seems to be neoatherosclerosis, and this is where OCT imaging might give us a lot of clues. So we did a pre-OCT run, and we are going to show the OCT now. We used a 6F radial axis, EBU 3.5 and a BMW wire, and we did the pre-run. Can we focus on the OCT? Can you see the OCT there?
Yeah, we can see you.
We'll start from the distal.
Yeah. Once the run is there, I can start. Yeah, you start from distal. You can see the distal vessel, the triple tri-layer is well maintained, normal, but can you stop when the disease starts? Distal vessel is quite good there. Next. No, can you?
The OCT imaging, please.
OCT, please. So distal to the stent itself, even before the stent struts are seen, the disease has started. There is a signal-rich, bright, fibrous neointima, just distal to the stent as well. And as you come up, you can see, stop there. You can see at around 2 o'clock, a calcific region with a bright, very, very signal poor and clear borders there. You can see at 2 o'clock, and between 3 and 5 may be a lipid-rich area as well. So there is a bright neointima all around, but this is not a pure neointima alone. There are features of calcification, there are features of lipid-laden neointima as well, classical neoatherosclerosis, but then we are going to see some more surprises along the way. As you pull back, more of lipid heterogeneous neointima, a lot of lipid material between 2 and 6 o'clock, very poor penetration there, and you can see lots of white thrombus there as well. Keep coming back. Yeah, that's a point of interest. You can go down a little bit more down. Go down distally. Yes. You can see a very thin cap fibroedema in the neointima around 5:36 o'clock. The measurement was only about 50 to 60 microns thick. And just as you come up, can you show there is a classical fibrous cap discontinuity, the classical plaque rupture with continuity between the lumen and the lipid pool. And of course, lots of clots there, some mixed clots, most of it is white clots. Yeah, you can see that. Go back, you can see the fibrous cap discontinuity, the classical plaque rupture.
Back.
Bit down. No.
Back.
Down. Yes. You can see the discontinuity in the fibrous cap there. So you got all the classical features of neoatherosclerosis, which is not uncommon in a 5-year-old aged DES. This is going to be a disease of the future. More and more DES might come with this. So we are not dealing with a classical pure neointimal tissue ISR. This is not the early stage stent failure where uncovered stent struts, malappositions are the issue. This is a neointimal tissue. Somewhere along the path, atherosclerosis has aggressively started invading the neointima. So neoatherosclerosis tells us the stent struts are all well expanded. There is no unexpanded stent. The stent diameters in the measurements in the OCT are 2.9 to 3, and very concentrically expanded stent all the way. So we are dealing with neoatherosclerosis stent. So what do you think? What are any thoughts about it? How do you approach? What is the management plan now? Stent. Your thoughts?
So you need to put I think you need to put in another stent to treat this atherosclerosis, and I think the stent needs to be longer than the index stent to have complete lesion coverage both distally and proximally. Maybe you need to predilate to be sure that you can get an adequate stent expansion before. So I would like to test the compliance of this tissue before and avoid a direct stenting. That's my impression.
Absolutely.
Yeah, I would agree with him. And I think your OCT very beautifully demonstrated the ruptured TICFA distal to the stent. It almost seems like that may have been the culprit lesion that then propagated proximally into the stent areas too. I think in all of these cases, whenever you're dealing with thrombus within stents, you have to pause and think whether putting another stent would be beneficial. And in this case, I would agree that putting a new longer stent covering the distal and the proximal portion would be probably the way to go. Tom, any thoughts?
No, I agree. I mean, you got to cover both old stent and the tissue that's diseased on both proximal and distal stent margins. So yeah, I agree. But longer stent and PCI.
Yeah. So as you rightly said, we tried the plain
Pre-dilatation
balloon.
image,
We,
please.
we did a pre-dilatation with a non-compliant 3 mm balloon. We didn't want to use a scoring or a cutting balloon because lots of thrombi were there. And classically, can you show the,
13th frame.
you could see that the classical watermelon seeding effect is there. Yeah, you can see that pre-dilatation with very slow inflations as well. Holding the balloon just kicks out of the stent. So this is a hard fibrotic tissue. You have to crack this to get in a stent for full deployment. And of course, next we went in very slowly, slow inflations, and we could break the tissue. We are not doing one more run because of the fear of dislodging whatever white thrombi there. So we are going to go ahead with a 3x38 stent straight from the ostium of the LED, taking care to avoid that large ramus. Next. So we're taking up with the 338.
If you look at your stent planning tool, it seems that, I think if you look at your stent planning tool, may indicate you need a longer stent, or what is the...
The original stent was 18 mm and the OCT measurement was about 34. And the measurement with the guide wire based strategy initially was about 34. So we're using a 38.
Okay, great.
Can you have some light here?
You know, another good option here. Another good option here would be considered laser PCI. And you have fibrocalcific, it's not purely calcific or heavily calcific disease with thrombus. So laser atherectomy would be an option as well, especially in stent.
Okay, so we don't have much experience about that. So we will go ahead with the Zines.
And also initially take a...
Yeah.
Do you have scoring balloons?
We have
Because
scoring
that's also
and
a way
cutting.
to avoid this slippage of the balloons.
Mag, we want, we'll take one shot in this view and then go into LAO caudal for, can you go to LAO caudal? Steep LAO caudal, 5632, double mag. The challenge here is the positioning of the stent because a huge ostium was there, center. Small test. Test. You hold the balloon. Don't inflate. I will tell you. What do you think of the position?
That looks pretty good. I think you're covering the areas of interest.
Two atmospheres. 4, 6, 8, 10. We checked the dye and then it seemed quite good. It flew into the dye was filling the ramus quite well. So we'll take a post dilatation 3.5. The distal vessel diameter reference was only 2.5. The proximal was about 3.5 plus. So we'll use a modified optimization technique, 3.5 15 NC. And then we'll go for a post run. So if it were a pure stent stent coverage issue with a thrombus, we could have thought of aspirations. But seeing a new atherosclerosis totally changes the plan. And here, I agree with your suggestion that there is no way to escape without putting in a second stent. 3.5, 15. So what are your thoughts about the post dilatation now?
I think you should definitely go for it, given that you're in the proximal part of the LAD there, and then follow that with an OCT run to see what the stent opposition looks like.
Yeah. Yes, 3.5, 15. You can come back to the AP cranial views. He is on ticagrelor aspirin and he received 7,500 heparin with an ACT now of intraprocedural 290.
Did you all give a 2B3A intraoperatively?
No, he received it pre-procedure elsewhere in another hospital. We are not routinely giving GP2B except in primaries when they are unprepared. But once he is on ticagrelor for 4 days now, and have a stent boost. The stent boost shows I think we are in the right place. Yeah. Gentle inflation, 10 atmospheres. Here actually the vessel is only 2.6 or so. Deflate. So we didn't want to go higher up there. Yeah, here we can go. 10 atmospheres. 14. Deflate. So the proximal can come to RFO caudal. You can give an inflation here. 10, 14, 16. Deflate. Okay. One more stent boost. I think we are outside. We'll go back in.
The first day here at C3, we had a talk about the duration of the inflation time.
Yeah.
When you post-dilated, there was
Stent
done
boost.
some bench testing. That I think you need at least 20 seconds.
30 seconds,
and maybe
20, 30
even longer
seconds.
to follow the
Yeah.
pressure. If it falls,
Correct.
stays. Yeah.
Yeah, you can give there. 18.
Of course, if the patient can tolerate the ischemia.
So the middle part of the stent, I think we'll give one more. Yeah. Yeah. 10, 12, 14, 16. Yes. I think now we'll go with an OCT. Get the OCT ready. We have some 10-15 minutes left, I think. Fluorosave. You can run the fluorosave. Yeah.
So what is your target with OCT? Is it a minimal stent area of above 6.5, or do you compare to the reference size? So what is your target now for expansion?
I think it should be definitely above 6.5 as a minimum, but I think we will be expecting somewhere around 7 or even more. With the 3.5, we have done the post dilatation. Ready?
The Lumen 4 trial, they want to have at least 90% compared to the reference segment. So it's very difficult to achieve. So they're
Yes.
really chasing the
Correct. Yeah.
minimum stent area.
Yes. See, yeah. So this time he has promised to be on a compliant DAPT regime. We have discussed these issues with the to the patient. Yeah. Come near, come near, come near. I think that's good. We'll start from there. Yeah. I think so. We'll take a longer run because we might miss the ostium. So longer 75 mm, 75, 74. I might have to give a bit the dye a bit longer, more dye. His renal function is normal. His LDL is uncontrolled, 130. So that could have been another issue as well. Yeah. You tell me. Yeah. Go to PA cranial. Can you show the OCT now? Yeah. So what are your comments on that? How do you feel? Show me.
I think the stent there looks pretty good, and there you have good apposition throughout the length of the stent, and I don't see any additional disruption at the edges.
Yeah, your point was wonderful. That you cannot get the classical stent diameters anyway in this case because then so much of neointimal tissue. You cannot achieve that. You cannot chase it and get it anyway. There are no obvious edge dissections, no significant tissue prolapses. What is the minimal lumen area now? Well opposed, no maloppositions. Just show me that. We can show the stent rendering as well. Can you show the stent rendering? Rendered stent display, and you go for opposition indicator as well. If you can see in the lower part of the screen, the opposition indicator, the white line above, it is all purely white. So if it is yellow, you know that maybe some 200 microns is there, but reddish in the parts in the line would be 300 microns. So the 3D, the advanced displays are good. The metallic stent optimization software is helping us to tell that the opposition is perfect. Can you tell us the minimum lumen area there in the proximal part of the vessel?
You have 4.96. Maybe longer post-dilatation will give you better.
Yes, I think
because
we will.
It takes some time for both stent to and the
I
tissue
think get the
to
post-dilatation balloon. Same balloon,
longer.
3.5.
I would suggest that because
Yes. I think we will need to go because this is you are focusing on the proximal. No, go into the stent. Yeah. Now what is the area like here? About 7.02. I think you are taking an oblique cut. 7.02. Go a little bit down. Yeah, there here. Yeah. No, inside. Keep going everywhere. Yeah. Now here. You show that it's about 6.8, but still we'll do one more post dilatation. A bit longer inflations. We're getting above 6.5 all the way. But the one point you show in the proximal part, I think you didn't take the full exact proximal part. You show me the MLA. This is a circ. You have seen some struts across the circ ostium. You have landed just exactly at the ostium, at the ramus, sorry. Yeah. So we are happy with the positioning of the stent. And there, what is the area there? Just a bit into the, yes, you tell 7.3. I think that was a wrong assessment you made. See, 7 above 6.8 and 7.35. but I think I can because I have taken the balloon anyway. I will go and give a little bit longer post dilatation. He has tolerated the
To
procedure
move the
well.
marker to the spot where the software finds the minimal stent area. Can
Yeah.
you show the OCT again?
Can you show the
OCT
OCT?
again.
Pardon, I couldn't get it. Yeah, I couldn't get you. Yeah. So run the OCT again as we are doing the post. One stent boost. Yeah. Show the OCT again. Focus on the OCT.
Okay, we'll just inform you that you have 3.5 minutes
Left.
So anything we should discuss with you before we lose the connection?
I think
Any
what I thought
comments
was
from the panel,
this
or-
exemplifies the problem of late stent failure with the DES, and this we are going to see more often in the future. And one has to recognize that the primary mechanism of late DES failure is predominantly neoatherosclerosis and its varied manifestations. Very rarely at 4 or 5 years down the degrading stent stage will you find a malopposition or uncovered stents. Very odd. So we have to treat it like the native atherosclerosis. In fact, neoatherosclerosis of the stent is more aggressive than the native neoatherosclerosis. You could see how we didn't do the OCT on the RCA, but from the angiographic appearance itself, we know that the appearances of neoatherosclerosis are grossly different from that of the native atherosclerosis. This is a final shot angiographic. Can you replay that? Can you come to PA caudal? Quite good. Can you show the fly through, the 3D on the OCT? So we showed you the 3D advanced display effect, the stent rendering. We showed you the opposition indicator as well, and the post pictures were good, and the fly through of that.
The stent is starting distally.
So you can see that.
That's a very nice result, and
yeah.
I think this case really illustrates the utility of OCT
Yes.
in understanding first the mechanism of failure in this case, and then finally for optimizing your stent result. I think that's very valuable.
Completely agree. I don't think you would have stented from the ostium if you didn't have this imaging. So you had
Yes.
really nice, complete lesion coverage and optimized results. Congratulations.
Thank you.
Yeah, very nice case. Appreciate the imaging.
Thank you. Thank you very much. It was a nice time. Thanks from all the team members here. I thank them as well. And greetings to Orlando.
Greetings, Orlando.
Thank you.
Thank you.